Yeah, doctor, you can continue.
Good afternoon, doctors. Welcome to you on this webinar on Carbetocin in action, case studies from labor room, brought to you by Hetero Healthcare. Hetero should give a snapshot of Hetero. Hetero has got 25 years of excellence with 36 state-of-art manufacturing facility, 300 plus products in portfolio and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. Hetero is has Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare provides 360 degrees solution, striving to fulfill unmet healthcare needs, reaching to customers across India with wide range of products encompassing multiple specialties and pioneering in quality and innovation. We have distinction of bringing 4 biosimilar products to market within 5 years of initiation. Although a lot is known about PPH and the problems that can happen if PPH is not managed properly and the importance of prophylactic management of PPH, there are many papers on the use of carbetocin in PPH, prophylaxis of PPH, but we always like to have our own doctor's experience on the PPH management. For this, we have got Dr. Kiran Rao with us today. Madam, welcome.
Thank you, sir.
Dr. Kiran Rao is a MBBS MS obstetrics and gynecology from Lady Harding's Medical College, Delhi, with fellowship in IVF and laparoscopy, Germany. Madam is director at RB Rao Memorial Multispecialty Hospital, Gonda. Done her MBBS and MS from, as I said, Lady Harding Hospital. Diploma in invasive surgery from KIEL, Germany. Advanced course in reproductive medicine from University of Schleswig-Holstein, Kiel, Germany. Sono endocrinology training from Dr. Nagori's Institute, Ahmedabad, by Dr. Sonal Panchal. Welcome, madam. And over to you for this presentation.
Yeah. Good afternoon, all of you. I'm going to present the overview of PPH. Sir, I shall share the screen.
If you want, madam, you can share the screen.
Okay.
If you want, then I will stop sharing and you can share the screen. I will come in the end for panel questions.
Okay, sir.
Okay, I will stop.
Yeah, so first we should know about the PPH. What is PPH? PPH is a loss of at least 500 ml blood following the vaginal delivery and 1000 ml following the cesarean section. And it is very common and it can occur. It is the leading cause of maternal mortality in our country, and it is the primary cause of death in maternal deaths globally. Sir, am I audible? Hello.
Yes, madam, very much audible. Slides are
Okay,
also seen clearly. No problem.
Okay. Actually, I'm not able to see the full screen.
Okay. You can put on the presentation mode.
So can you please start sharing screen?
Yes, I will start. You can, yeah, no problem, madam. You stop sharing. I will take over.
Okay.
Yeah. No, you can stop sharing, madam.
Yeah.
I will take over. Yes. Is it better now?
Yeah. Now it is visible.
Good.
Okay. So next slide, please. Yeah. PPH, it's unfortunate yet common. The maternal mortality accounts for almost 35% of maternal deaths globally, in which India is having almost two-thirds of this attributes to PPH, means 25.7% of global deaths. And India has an unexpectedly high maternal death rate of 540 per 1 lakh live births. And in developing countries, it is almost 240 per 1 lakh live births as compared to 16 in developed countries. The global PPH incidence is around 14 million women suffer from PPH, and the incidence reported as 2 to 4% in vaginal delivery and 6% after cesarean section. Next slide. Yeah. Now, we should know about the etiology of PPH. Why it happens? Because of the uterine atony. Uterus is not able to contract. It may lead to continuous bleeding. And there are some certain coagulopathies which leads to the failure in clotting, and this also leads to the PPH. Then there are many other things like uterine trauma, means during delivery, if there is any injury to birth canal or uterine rupture or inversion or any lacerations or cervical trauma, then it can lead to PPH. And sometimes there is some residual or retention placental products, or can be abnormal placenta. So this all lead to the PPH. Now, what are the clinical findings? Clinical findings in PPH are abdominal tenderness, the circulatory collapse, abdominal girth may increase, the uterine contractions may be lost in uterine rupture, there can be increase in pulse rate, or certainly the vaginal bleeding. So PPH is again classified into three: mild, moderate, and severe, on the basis of blood loss, blood pressure, and the symptoms and signs. In mild, there is around 1 liter to 1.5 liter blood loss in almost 15 to 25% of patients. And there is slight fall in BP, like 80 to 100 mm of Sg. Patient may feel weakness, sweating, tachycardia. And in moderate, it can be a blood loss of 1.5 to 2 liter, and there is marked fall in BP. In systolic BP, around 70 to 80 millimeter of mercury. Patient can present with restlessness, pallor, oliguria. In severe PPH, the blood loss is more than 2 liter, and there is profound fall in blood pressure, like 50 to 70 millimeter of mercury. And symptoms are more severe, like collapse, air hunger, and urea. So PPH is having so many clinical findings, and obstetrician is this is nightmare for obstetrician, because we nobody want PPH to see severe PPH in life. It is very, very traumatic. Next. Yeah. The initial evaluation includes the patients. I already told about the mild, moderate, and severe. And evaluation also include the assessment of patient's status, presence of tachycardia, hypertension, vital signs to be assessed, and blood loss. Examination at the time of hemorrhage, like assessment of the genital tract for lacerations, hematoma, signs of uterine rupture, manual examination for retained placental products, assessment with ultrasound to check if the uterus is non-contracted, and evaluation for the uterine inversion. In lab assessment, we can go for complete blood count to check hemoglobin, hematocrit, and platelets. Coagulation profile, PT, PTTK, INR, and assessment of fibrinogen, D-dimer, and all. So the diagnosis depends on all those factors. Now, what is the approach towards PPH? First, we will see the uterus tone, means it is atonic uterus or it is contracted. If it is if the uterine tone is like it is contracted, then we are pretty sure that there can be other reasons like coagulopathies, tears, trauma, retained tissue, and all. But if the uterine tone is not good, means it is like just a dough uterus, means the tone is very low and the patient is bleeding, So we should palpate the abdomen to feel the relaxed, boggy, and soft uterus. The fundus can be felt above the umbilicus if uterine cavity is filled with blood and clots. Investigations already told you: CBC, coagulation profile, urea electrolytes, abdominal ultrasound. And the management is with uterotonic agents, uterine balloon tamponade, hemostasis algorithm. And if the tone is good, then we can look for other factors like tears or trauma, in which also there is a clinical finding like bleeding. And it can be due to uterine rupture, extension of uterine angles, tears during cesarean section. And there can be other extragenital causes like rupture of ovarian or splenic vessels in cesarean section. So investigations are like inspection during cesarean section by externalization, and ultrasound may also help identifying free fluid in patients with uterine rupture. Management is repair of identified genital tract trauma, pelvic arterial embolization. That is the last resort. May be required in cases of broad ligament or supra-elevator hematoma. The third cause is, sir, previous slide, please. The third cause may be retained tissue, in which also we should examine the patient under anesthesia, because it's very painful to examine bimanually after delivery. So one should examine under regional or general anesthesia, and should take out all the placental products and membranes. And fourth is coagulopathy. For coagulopathy, again, we will go for full blood count, coagulation profile, urea, and electrolytes. The management is medically, we should replace the blood and coagulation factors and platelets. In surgery, only with trauma or atonic hemorrhage unresponsive to medical management, we can go for cesarean hysterectomy. So attempt should be made to identify the cause in women who are bleeding in parallel with resuscitation. Now, we are coming to the very important slide, that is why carbetocin is preferred over other uterotonic agents, because it is available in a room temperature and stable formulation is there, and the convenient vial presentation is there. There is no any need of logistics like in syntocinon. It's like one vial contains 5 unit. So sometimes if we'll ask any PG to give 20 unit Cinto, so she can or he can forget what is the unit content in a vial. So there is no any logistic applied here in this carbetocin, and it is heat stable also, at a room temperature. But why oxytocin is not stable at room temperature, it requires around 4 to 8 degree Celsius. So the formulation is not available for oxytocin for heat stability, and previous formulation of carbetocin were there, which were also stored between 2 to 8 degrees Celsius. But this carbiac is not like that. It is available in a room temperature, and it has a convenient vial presentation. And in poor country like India, which is a developing country, in which there are so many maternal deaths due to not application of uterotonic agents, or not the uterotonic agents may um, not act in that way. So this is a very good product for developing countries, because we don't need any refrigerator, and it is a stable at room temperature. As I have already told, the shelf life is very long, means 24 months at 30 degrees Celsius and 75% humidity, and it avoids need for cold chain storage and logistics, and it is a provided in a vial. It can be given at the crowning, at the delivery of anterior shoulder, at the end of second stage of labor, following the delivery of placenta. And the prophylactic use is a prevention of PPH in active management of third stage. And therapeutic use means management of PPH. Other molecules can also be given like oxytocin, ergometrin, synthometrin, misoprost, but carbetocin is much better than other products. Currently available uterotonics in India, I have already told: oxytocin, misoprost, ergometrin, cabiprost. The oxytocin onset lasts for 2 to 3 onset starts at 2 to 3 minutes, and it lasts up to 15 to 20 minutes. And we there is a question in direct IV oxytocin because it can lead to uterine rupture, or it can, in cases of cardiovascular failure and heart disease, it should not be given. And in misoprost, the onset starts at 3 to 5 minutes, peak at 20 to 30 minutes, last up to 75 minutes. And it can lead to shivering, slight rise in temperature. That is very common. And there is no any contraindications of misoprost. In ergometrin, like methergine, zero point 0.2 milligram IM is given. Onset starts at 2 to 7 minutes, lasts for 2 to 4 hours, and it can increase the risk of retained placenta, nausea, vomiting, headache, hypertension. It is contraindicated in hypertensive patients and Rh negative mothers. The other uterotonic agent is carboprost, that is given at dose of 250 microgram IM, and onset starts at 1 to 2 minutes, lasts for about 15 to 20 minutes. The side effects are like vomiting, which is very common with carboprost, and it should not be given in bronchial asthma patients. The concerns with available uterotonics is, I already told that all require the spatial storage condition like 2 to 8 degrees Celsius of temperature, and the dose is oxytocin require multiple dosing regimen. It is short acting, multiple doses may be required. Overdose or prolonged use can cause water intoxication, and the prolonged use can also lead to the uterine atony. In methergine, it requires also spatial storage associated with significant increase in side effects, needs to be avoided in hypertensive patient. Misoprost is also can be used given in for preventing PPH, and it has more side effects like shivering, pyrexia, and it should be used in combination with patients with cardiovascular disease. Caboprost, it should be avoided in asthmatic patients, and it also requires spatial storage condition like 2 to 8 degrees Celsius. So most of the uterotonics require spatial storage condition, and it is given in some dosing regimen. This is a uh, this is one of the thing that uh, we are means Carbetocin is more superior to those products, and it is a unique uterotonic. The thing is, the chemical structure of oxytocin and carbetocin is somewhat changed, and it was created by making several modifications. It increases increases the half life, reduces the enzymatic degradation, and the drug is synthetic long acting analog of oxytocin. Therapeutic indication PPH, and the it one vial contains 100 microgram of carbetocin in 1 ml solution for injection. Is it a solution to all the concerns of oxytocin? Yeah, it can be addressed by carbetocin. Antidiuretic effects, water intoxication, these all are drawbacks. Multiple dosing regimen, short acting, repeat doses required, failure of PPH prophylaxis, stability and quality issues. So carbetocin is certainly superior to oxytocin. The clinical evidence on carbetocin, there are many studies. One of the study is this one. It is for preventing PPH. This is a review article in which the oxytocin was compared with carbetocin, and the data is like use of carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics for those who underwent cesarean section, and it was also associated with a reduced need for uterine massage following both cesarean and vaginal delivery. And it was also compared to methergine, and the data was like carbetocin showed a lower mean blood loss in women. Risk of adverse effects like nausea and vomiting were significantly lower in carbetocin group, and the incidence was also significantly lower of postpartum hypertension. There were 11 studies, and it involves 2,635 women, in which we came out with the result that carbetocin is superior to oxytocin as well as methergine. This summary already we have told about talk about all these things, that it is was as effective as oxytocin in prevention of PPH, showed lesser mean blood loss in some studies, enhances early postpartum uterine involution, and it showed fewer women requiring additional uterotonics. And it also showed fewer women requiring uterine massage, lower blood transfusion rates, and it has lower incidence of postpartum anemia in some studies. Carbetocin versus symptometrin. The summary also came out with the same results, like it showed lesser mean blood loss in some studies, showed fewer women requiring additional uterotonics in some studies, lower incidence of postpartum anemia, lesser incidence of nausea and vomiting, and symptometrin was associated with increase in systolic and diastolic BP, so it is contraindicated in hypertensive patient, unlike carbetocin. Carbetocin versus misoprost. The summary is carbetocin is definitely more effective than misoprost in prevention of PPH, and it is also associated with lower duration of third stage of labor, lesser mean blood loss in some studies, fewer women requiring additional uterotonics, and fewer women requiring uterine massage, showed lower blood transfusion rates, and adverse effects were common with the misoprost, like in shivering, increase in body temperature, all that. There are many studies, and this is the second one study we are talking about. It involves 1,35,559 women. It is a large study, and it is a network meta-analysis, compared 7 uterotonic agents against each other and against women receiving no uterotonic. 3 most effective drugs for prevention of PPH, more than 500 ml, were ergometrin plus oxytocin combination, carbetocin, and misoprost plus oxytocin combination. So these were more effective at preventing PPH more than 500 ml compared with the oxytocin, the current standard. 2 combination drugs, however, are associated with significant side effects that women might find disturbing compared with oxytocin. Carbetocin may have some additional benefits compared with oxytocin and appears to be without an increase in side effects. So, obviously, simple carbetocin is much better than the two uterotonic therapy. This is also a summary of treatment effects of uterotonic agents versus reference agent oxytocin on beneficial outcomes. And the carbetocin and misoprost plus oxytocin is clearly stand out in terms of possible benefits compared to oxytocin. This is the summary. So, WHO recommendation is uterotonics for the prevention of postpartum hemorrhage is carbetocin. The summary from analysis of data and literature, that it is long acting, does not require prolonged IV infusion, administered via a single IV injection. That I'm telling since beginning, that it requires no any logistic. You can tell your sister that please give one vial IV with no need for repeated injections. And it has well established dose. Means 1 ml vial contains 100 microgram dose. And it is validated for the presence of PPH. There is lower affinity to the vasopressin B2 receptor compared with oxytocin. Possibly less blood loss and requirement of additional oxytocins. Stable at room temperature. Seems like an ideal uterotonic but lacks room temperature stability. Onset of action of carbetocin starts within 2 minutes, unlike other uterotonics, which requires at least 3 to 5 minutes for the onset of action. The half-life is also more, 33 minutes in IV, 55 minutes in IM injection. Duration is 60 minutes. Duration of action is for 60 minutes IV, 119 minutes IM. The doses and mode of administration is 100 microgram administered IV, slowly over 1 minute, or IM, and it must only be administered after delivery of the infant and as soon as possible after delivery, preferably before the delivery of the placenta. And it has single use only. No further doses should be administered. The storage is also room temperature less than 30 degree and 75% relative humidity. There are many clinical studies which we already talk about, and this is the one of the largest study, which is WHO champion trial, means carbetocin hemorrhage prevention trial. It was conducted by WHO Department of Reproductive Health and Research, in which 30,000 women enrolled across 10 countries, including India also. And the design of study was double blinded randomized trial. The primary outcomes came out as the proportion of women with blood loss of at least 500 ml or the use of additional uterotonic agents. The proportion of women with blood loss of at least 1000 ml. So, carbetocin and oxytocin were compared in blood loss of more than 500 ml patients, where 14.5% efficacy came out for carbetocin and 14.4% for oxytocin. Likewise, blood loss of more than 1 liter, in which carbetocin has an efficacy of 1.51% and oxytocin is 1.45%. And safety means at least one anticipated adverse events, 4.9% for carbetocin and 4.7% for oxytocin, and at least one serious adverse events. In carbetocin only 0.7%, in oxytocin only 0.6%. So the frequencies of the expected adverse events didn't differ significantly between the two groups. The frequency of blood loss of at least 500 ml or the use of additional uterotonic agents with carbetocin was proved to be non-inferior versus oxytocin. So the use of additional uterotonic agents, interventions to stop bleeding and adverse events didn't differ significantly between the two groups. So carbetocin was found out to be non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic agent. This was the summary of this WHO champion trial. This is one of the Cochrane review in which carbetocin for preventing PPH. In this Cochrane review data from 11 studies, we have already talk about this study. The first slide only, in which 11 studies were enrolled involving 2,635 women. And for women who undergo a cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. And also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal deliveries. And it is also associated with significantly fewer side effects. There are many guideline recommendations by the Society of Obstetrics and Gynecologists of Canada, Danish, Russia, Polish, China, Philippines, Mexico, Queensland, and all those Society of Obstetricians and Gynecologists came out with the recommendation of the PH prophylaxis as carbetocin is much better. So WHO in 2018 recommends guideline for PPH prophylaxis that only one of the following can be used, like oxytocin, carbetocin, misoprost, ergometrin, or oxytocin and ergometrin fixed dose combination. By the Canada Society of Obstetrics and Gynecology, the recommendation is carbetocin 100 microgram IV bolus. According to the New Zealand Obs and Gynae Society, active management of third stage of labor by the prophylactic uterotonics. The FIGO, Federation of Gynae and Obs, carbetocin is one of the recommendation for PPH management. By the Germany Obs and Gynae Society, carbetocin is again recommended for the prophylaxis. And in France also, the Obs and Gynae Society recommended carbetocin. So by this slide, we came out with the conclusion that most of the Society of Obstetrics and Gynae, they have recommended in their guidelines for PPH prophylaxis as carbetocin. Now my experience with carbetocin, the smarter, superior, and safer choice in PPH management.
Yes, madam. Madam, how long have you been using carbetocin?
Sir, I'm using since I think 1 year.
It's 1 year. And generally, which is the route that you prefer, IV or IM?
Sir, we are giving IV.
IV as a
Yes.
slow IV
Slow,
injection
slow. Yes, sir. Slowly
over
IV
one
or
minute.
either in the
Yes,
drip.
and the drip. And what is your general experience, about efficacy and as well as tolerability?
Sir, my result is excellent. We are
Excellent.
using in every
Yeah,
delivery, in
correct.
vaginal as well as cesarean. We
Yeah,
are not using it as a therapeutic drug. We are using it as a prophylactic drug because
absolutely.
we
That's the
don't
way it
want
should be.
any
Yes,
PPH to
yes, yes.
happen in our hospital.
Exactly. That's the
So
place
for
it should be
each and
used.
every cases, we are using left and right this Carbiate.
In fact, when you were describing about PPH, you rightly said that PPH is one thing which one should never say. The only thing you said is severe PPH. I would go one step ahead and say no PPH should be seen by anyone because
Yes,
PPH
sir.
is yes is a, a nightmare, literally a nightmare.
Yeah.
No one wants. And have you seen any failures with Carbetocin?
No, sir, not yet, and I don't want to see also.
Yeah, yeah, yeah. God bless you. Should never see.
Yeah, sir.
Although in our this thing we say always expect the unexpected. You do not know which patient. Suddenly the patient drops in. I had
Yeah,
seen
yeah.
one patient in JJ hospital. The patient was recovering smoothly after delivery, and suddenly there was PPH. And I'm talking about ancient times in late 70s, and we had only oxytocin and methergine at that time.
Yes,
The
sir.
whole hospital was there. I mean, which patient profile you can expect PPH?
Sir, if the hemoglobin is very less, severe anemic
Okay,
patient,
okay,
severe thrombocytopenia, severe
okay.
any coagulopathies, any high risk pregnancy like hypertension, preeclampsia, eclampsia, or like in many patients who are APLA positive and all.
Yeah, yeah,
So
yeah.
we are expecting to have PPH in those patients.
Even diabetes can predispose the patient, fibroids, diabetes by reducing the
Sir,
tones.
in diabetes also, but not so much.
Not so much.
I am afraid of PIH patients more in
Okay, yeah.
not
Yeah, yeah,
diabetes.
yeah, yeah. I mean, so many complications. PPH is only one of them. When would you prefer carbetocin or oxytocin? I mean, you have been using it almost all, but specifically where the doctor should go for carbetocin or
Sir, I am
oxytocin?
using carbitocin in all
All the patient.
cases. If
The
you will ask
med-
me which patient to be preferred, then cesarean
okay,
section patients are more prone for PPH.
PPH. So
That
high risk
I've
patients
seen.
should be preferred
Yeah, yeah,
carbetocin,
yes,
high risk.
yes.
And anyway, looking at the risk that PPH can have, patient can go into any complication. Better use the
Yes, sir.
best one available at this point of time.
Mm.
Can we use you have got any experience of use of carbetocin in retained placenta?
So, no experience till now.
Okay, no problem. What is your opinion about retained placenta
But
using
I
it?
think
It
this is
can
a
be.
very good drug, and we are using oxytocin. So why should we not use
Yeah, yeah, yeah.
carbetocin in place of oxytocin? Because of the chemical structure, it is more better. It
Correct,
gives
correct, correct,
prolongs half life and
correct.
decreases the enzymatic degradation. So it should be used.
Correct. And RH negative mothers,
Yes, certainly, sir.
yeah.
Definitely.
Because if they get PPH, then you will not get blood, especially in the
Yes, sir.
periphery. Yeah, that
Yes,
could be
sir.
a big
Yes,
thing.
sir.
Yes. If a doctor uses carbetocin for prevention, can a doctor use carbetocin for
Yes,
prevention? If
sir. Yes, sir.
oxytocin, yes, yes. Because oxytocin, the duration of, by then the effect would have gone.
Yes, sir. Sir, one question I want to ask. Why carbetocin can't be used for labor induction? Because this
I suppose
structure
because
is similar.
no, because I suppose the strength of contraction will interfere with the labor process.
Okay.
That's a possible thing which I think, do not have answer to this, but the only logical thing which I think is that the force of contraction is so hard that it may interfere with the whole labor
It
process.
can lead to uterine rupture and
Yes,
all.
yes, 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 yes. And because oxytocin all said and done, the action is smooth. And yeah, this is what I feel. Although it's not documented anywhere why it should not be, but this is my understanding.
Yes, sir.
In which cases you would prefer IV over, or is there a place for IM? I would put it
Sir,
that way.
most of the cases we are using
Yeah,
IV only,
IV, yes. Maybe
slowly.
where the duration of action needed is longer, maybe people can prefer IM.
Yes, sir. Yes, sir.
If the patient is not responding adequately with carbetocin, God bless, it should never happen. What additional uterotonics would you use?
Carboprost,
Everything available,
everything,
whatever.
balloon
And,
tamponade,
yeah, yeah,
Balen
yeah.
suture, everything, sir.
Everything that we know. I suppose the basic advantage of carbetocin in all this is, that you don't require
We
a
told
heat.
about.
Yeah, yeah, yeah. Key, I mean, the what is a cold chain or single dose.
Yes, sir.
But besides that, how commonly you have seen oxytocin and ADH side effects? Although we say that, have
I've
you seen?
seen I've seen in
Okay,
previous LSCS
okay,
uterine
especially,
rupture happen.
and ADH retention happened.
Yeah.
Okay, and misoprostol
Sir, only increase in temperature means
temperature,
shivering and all.
okay.
Yes.
Carboprost could be an issue,
Yeah,
because
sir, it is
vomiting,
avoided
diarrhea.
in
Yes, yes, yes.
asthmatic
And
patient.
asthmatics also. And methyl argometrin, the sudden blood pressure can.
Yeah, yeah. It is, we are not giving methergine,
Methyl,
right?
yeah,
Yes, it's obsolete, I think.
absolute, absolute.
Nobody is giving methergine because it
Meth-
has much.
Suddenly high pressure, blood pressure should.
Yes, sir.
Should carbetocin be kept as a reserve drug, or it should be used as first
Sir,
line?
but for me, it is a first line drug because I'm using.
Almost all the doctors have said that, I mean, where it's not possible to use it, maybe reserve,
In
but not by
every
choice, yes.
case, we have
Yes, correct, correct,
carbetocin in OT.
correct. The best, I mean, for oxytocin, the issue could be maintenance of cold chain, not in the hospital, during transport process, and that could again
Yeah, yeah.
interfere with
Yes, sir.
efficacy. Yes, yes.
And sir, there is so much delivery load in India, so
Yeah, yeah,
nobody
yeah.
can means keep that in fridge. In lady harding,
Absolutely.
we used to do because we have so many
I mean,
sisters.
those are big hospitals. There is
Yeah, we
possible
have
in
so many
periphery.
staff,
Yeah,
but
yeah, yeah,
in
yeah, yeah.
PHC, CSC, and
Exactly,
a
exactly.
periphery, like we are working here in Gonda, and it is
Gonda.
nearby
Yeah,
Lucknow. It is a means very periphery from
correct, correct, correct.
means periphery in UP. So we are seeing each and everything happening for maternal increasing in maternal mortality.
Absolutely. Yeah,
The patient is dying, just they are not giving uterotonics
yeah,
just because of this,
yeah,
and it is very heartbreaking for us.
yeah, yeah, yeah. I mean, there are a lot of issues along with this.
Yes,
The patient's relatives, this, that. I mean, uh,
yes, sir.
how would you compare adverse effect of carbetocin or oxytocin? I mean, you have not seen any adverse effect, so it's no.
No, sir. No,
Yeah,
not so far.
also. And one line message to the audience about carbetocin.
Carbetocin is certainly a best drug as a uterotonic for
Uh,
each delivery, means vaginal as well as cesarean delivery. And it is stable at room temperature.
correct.
It requires no any logistic, which I am saying since beginning, because we are asking our junior staff or our sisters to give all those drugs. So if they have done some mistakes, we have to be like very very vigilant in those things, because one thing happened when I was PG in Lady Harding and PG first year. Then my SR told one resident that give uh, 5 unit of oxytocin to this
Oxytocin.
patient, and she was not aware, because in PG first year, right from first or second day of PG, she was like, means she didn't ask anybody, and she gave 5
Oh God.
ampules of oxytocin to a
My
previous
God.
LSCS patient, and that patient had sudden loss of contractions. Then a uterine rupture happened, the baby died, and then we traced what happened. Then we came out with this thing that she was given with this 5 ampules of Cinto. So that was the thing, and means I
Yeah,
don't
yeah,
know.
yes,
There
yeah,
is nobody's mistake, but
yeah,
this logistic we
correct, correct.
need. And in
And
carbetocin, it's not like that.
not like
And we are
single injection,
working
please.
in a periphery where it's very difficult for all staff to teach
Correct.
all those things. How much,
Yeah,
how, what is the moderate rate, what is the
correct,
60
correct.
drops per minute, what is 30 drops
Oh,
per minute. So we can't make that chart which we were using in labor room in Lady Hardy.
yes, yes, yes.
So this is definitely a better drug. It is not so cost effective, but when
Yeah,
you
yeah.
when
Looking
you
at the
just
advantage, overall
compare
advantage.
with
Yes,
so
yes,
much vials of
correct.
oxytocin, then it
Oxytocin.
is certainly a cost effective.
And you rightly said they use the word logistic.
Yeah,
Logistically, this drug. And madam, what is your opinion about a prefilled syringe of
sir.
carbetocin?
Sir, it is certainly better.
सही है ना?
हाँ सही है सर, बहुत सही है.
Because you will save time and you will save every drop, which of course, even if we take, forget the nursing stuff, even if we take, there's always likelihood of some drop remaining, the spillage, etc. I mean,
I'm doing
prefill,
IVF practice here, and All
Oh,
hormones are nowadays coming in PFS only.
yeah, even
Yeah.
tranexamic acid is coming in PFS.
Yes, sir. Yes, sir.
Yes. Anyway, madam, thank you so much. It was nice hearing your info, experiences and insights. Thank you
Thanks a
so
lot,
much.
sir. Thank you so
Thanks
much,
for
sir.
your. Thank you all the doctors who took time from their busy schedule and attended this webinar. Thank you marketing and sales team of Hitro for conceptualizing and operationalizing this. Thanks IT team for your IT support. And once again, thank you, madam, for your excellent insights. Thank you.
Yes,
I'm
sir.
sure the audience must have benefited. Thank you.
Thank you, sir.
We can sign off. Ravali, we can sign off now.
Thank you.